to the organisers for the opportunity to present our work today, which, as you mentioned, is Approaches for Registering Adaptive Trials in the Australian New Zealand Clinical Trials Registry, or ANZCTR. Before we get started, we would like to acknowledge the tradition of custodianship and law of the Wangal and Gadigal lands of the Eora Nation that we are presenting from today. We pay our respects to those who have cared and continue to care for these lands. So the ANZCTR is one of 18 clinical trials registries that contributes data to the World Health Organization International Clinical Trials Registry platform. Trialists are encouraged to register their trial on a public registry prior to enrolment of the first participant, and this is referred to as prospective registration. Trial registries fulfill multiple roles, for example, acting as a platform where potential participants can search for active trials and also acting as data repositories for results reporting where possible. As a member of the primary registry network, the ANZCTR must collect and display minimum trial information for each registered trial, and this can vary depending upon the trial design features. Adaptive trials, which may include platform and multi-arm, multi-stage trials, offer greater flexibility to researchers and also benefits for participants, as a number of different interventions or treatments can be assessed within the same trial platform. These trials use pre-specified criteria to introduce or remove different treatment arms across the life cycle of a trial, and this is different to what we would consider as a traditional trial approach, where all of the arms are considered and stay the same from the beginning to the end of the trial. Because of the changing nature of adaptive trials, it can be quite difficult to capture the design details that are required within a registration record. Some of the known pain points that ANZCTR staff have come across, which may be shared with ethics committees and research officers, are that there is minimal consistency in the trial design terms used. As you can see from this word cloud on the right, there are multiple different and varying words that people would use to describe their trial, and quite often the choice of design term used comes down to researcher preference. Multi-centre trials that are recruiting internationally may also require separate registration records to be created and displayed on different registries in order to satisfy international legislation. So, for example, if your trial is recruiting in the United States and Europe, you would be required to register your trial with clinicaltrials.gov and the European Union Clinical Trials Registry. And because of the different nature of information required by each of these registries, the information presented in the records may also slightly differ. As I mentioned earlier, these trial designs often involve different recruitment arms, which may be recruiting at different times throughout the trial. So you could possibly have a 5-arm trial where 2 arms are recruiting, 1 is closed and 1 is pending review. And it's not always easy to present all of this within a single trial record. So the aims of our project were to examine the current registration practices for these adaptive trial designs within the ANZCTR, and also to provide an overview of ongoing discussions across the World Health Organization Clinical Trials Registries network. So to discover the types of registration practices within the ANZCTR, we conducted an audit of the public database. Multiple searches were conducted within the ANZCTR between inception in 2005 and July 2023 to identify adaptive trials. As I mentioned previously, there is a wide diversity in the terms used to describe adaptive trials, so we ended up conducting 13 separate searches with each of these terms to capture as many adaptive trials within the database as we could. We used the criteria of multi-arm trials that may add or remove treatment arms over the course of the trial to determine which studies would be included as adaptive trials and those that would be excluded. The results from each search were then downloaded into separate files and combined for screening against that inclusion criteria. Once we had identified the adaptive trials, the registration method used for each adaptive trial was recorded together with key trial information. So, referring back to our criteria that an adaptive trial is one with a pre-specified plan for the addition and or removal of treatment arms over the course of the trial, from our searches, we identified 12 adaptive trials that had been registered with the ANZCTR throughout this time period. And you may be thinking that it seems like a fairly small number, but this actually eventuated into multiple registration records, and I will go through that shortly. So of our 12 adaptive studies, you can see that the majority were investigating cancer. However, we did see a small increase in COVID-19 platform trials throughout the pandemic. The majority of these trials were also designed as randomized control trials, meaning that within their multiple arms, they had one control or comparator arm, and this may have been shared across the multiple treatment arms, or it may have been an individual control arm for different pairings of treatments. And randomization means that patients were randomly allocated to each of those arms. It was not the investigators choosing that. So as I mentioned previously, we did end up with multiple records for some of these adaptive trials. So in this graph, you can see that we have what are referred to as master protocols in this lighter blue and sub-studies in the darker blue, as well as single registration records in the teal. We have seen an increase in the number of adaptive trials registered over time. We did have 6 of these trials that were registered as a single registration record, meaning that the trial information is presented in one form only, whereas the remaining 6 were split into what is termed a master protocol or overarching protocol for the study, and then the sub-study protocol records were then registered separately to define each of the different treatment arms, and I can go through this in more detail. So why do we have these 2 different approaches for registration? Well, not all adaptive trials follow the same design, so we can't provide a one-size-fits-all approach to registering these studies, and we want to make sure that the information provided within a record firstly meets the minimum requirements of the WHO, but is also useful and understandable for potential participants who are looking for these studies. So the first approach that we have reviewed is the master protocol with separate sub-study registration records approach. And this is typically used for adaptive trials that are known to evolve over time. So the first adaptive trial that we registered in this fashion was the Cancer Molecular Screening and Therapeutics, or MOST program. The researchers came to us in 2016 and said, we have this novel trial design. We don't think many people have done this before, but we want to conduct a series of single arm studies that are going to sit under one platform. So the investigators will be the same, but we're going to look at a number of different unique cancer subtypes and then specific treatments for those cancer subtypes. And noting that there were going to be different cancer populations, we knew that it was going to be quite difficult to capture all of the inclusion and exclusion criteria for each of those studies within one record. So after discussions with the researchers, we determined that it would be best if we registered a master protocol that could then be linked to each of the sub-studies, and they would then be registered separately over time as these were funded and treatments became available. So as you can see, this did result in 19 separate sub-studies being registered for the MOST program. But as I mentioned, because the trial information for each of those sub-studies is different, this is the clearest and most easily approachable way to describe each of those sub-study types. So the flip side of that is we do have some adaptive trials that are more finite or captured within a single registration record. And a good example of this is the automatic trial, which was looking at a text messaging intervention to improve immunization coverage. So we could see when this trial was submitted to us that there was only one health condition or disease of interest. The inclusion and exclusion criteria for the entire study were going to be the same across all of the arms. And they had specified in their analysis plan that they were going to start with 12 intervention text messaging arms and a single control arm. And over the course of the study, they would conduct interim reviews to remove arms, but they weren't going to add any more additional arms throughout the study. So after discussion with the researchers, we felt that this was going to be the most appropriate to register in a single record. So this is how we are currently approaching registration of adaptive trials within the ANZCTR, but we're not sure how other registries within the World Health Organization are approaching their registration. So in order to discover this, I will hand over to Melina.
Thanks, Peter. Hi, everyone. So for part 2 of this project, we discussed the process of registering and reporting results of adaptive trials with the, I'm just seeing if I can, with the UK and the US registries, and also with representatives of the at the WHO. And it was clear from these discussions that there's no uniform approach across the registries. And the US-based clinicaltrials.gov registry has published an article that recommends separate registrations for each sub-study for one master protocol, and they highlight that there are some exceptions to this rule. And this this approach by clinicaltrials.gov makes sense, given the legal requirements that exist to report trial results within specified timeframes for certain trials on clinicaltrials.gov. And to arrive at this decision to have separate records for each sub-study by the clinicaltrials.gov registry came about through extensive consultation. There was a long gestation period to arrive at this recommendation. So from these, sorry, is everything all right? Yes. From these informal discussions, we did arrive at some starting points. And the first is that we do need some consistent terminology for these more novel trial designs and include these terms in titles so we can properly search for and we can interpret the key details from these sub-studies. It's also important that we make sure that registries have the option to create links across records for master protocols and sub-studies, both within their registry, but also across registries. And this is important because, as Peter has mentioned earlier, a country might take part in only one sub-study, but it still needs to link to its parent or its master, which may exist in another registry. And this helps in understanding whether these trials are actually part of a larger trial. So in conclusion, there are variations in how these trial designs are registered at the ANZCTR and across registries. And this variation seems completely understandable, and it's because of multiple factors. For example, different treatment arms will start or be open for recruitment at different times. So a registry needs to be able to accommodate this and also allow the trialists to add information prospectively. It also depends on an analytic approach of the trial results, and this could, for example, include pooling of data across sub-studies. So in some cases, having all the information in one record may make more sense. Overall, the ANZCTR does take a case-by-case review process, and we really want to have open communication between the ANZCTR team and the trialists about their adaptive trial, because this helps us plan the best approach for registration and ultimately will reduce the back and forth between the trialist and the ANZCTR team. So what do we think this means for both the registry and the Human Research Ethics Committees? Well, we have a few ideas or observations. We think both groups probably experience similar procedural challenges when approving or facilitating the registration of adaptive trials. And we think that there would be value in better understanding each other's decision processes and the pain points on whether to ask for one or multiple applications or registrations. By collaborating, this is an opportunity for us to discuss where harmonisation in our processes could potentially occur, create some exemplars, and use this information to clearly communicate with trialists. And I think that this will also help inform the design of the National One-Stop Shop. And in the meantime, as a simple measure, I think for both registries and ethics, we could look into having some shared reference documents on terminology used for these types of trials. We know that ACTA has drafted a document outlining the terms and definitions, and we're keen to use this once it's finalised. So in sum, the ANZCTR is keen to start conversations with the ethics committees to see where harmonisation could occur. So thank you. And any questions?
Yes, there is one question for you. How would you
Yes.
suggest HREC's review platform adaptive trials with multiple sub-studies, such as MOST? Should they be done as a single study with multiple amendments per sub-study, or reviewed as a new study per sub-study / addendum, considering the administrative burden on both researchers and HRECs?
Would you like to go first, Peter?
Sure, that is an excellent question. I think we have tried to reduce administrative burden as well, and we understand that having multiple registration records and needing to keep each of those up to date can add to that burden. We do understand, though, that big platform trials like this involve a lot of different people. So probably the best approach would be to have a central protocol that goes to their preferred ethics committee for the master protocol, and then depending upon where the sub-studies are being undertaken, obviously it would need to have local review at each of those ethics committees. And I think that's probably the easiest starting point, but because of the nature of the studies, I understand the risks involved can change with each arm and each population that's being studied, so there might not be an easy approach to that question.
Thank you. And a request. If you could provide a link or a full citation for the BMJ article you cited on registering sub-studies, that would be good. And if you can
Yes.
just put that up in the chat room the next 10, 15, whatever minutes, that'd be great.
Will do. Thanks, Hudson.
And thank you both. Next topic is